Thank you for the IHOP organizing committee and the scientific committee for this kind invitation to speak about the controversy, or let's say which class of GLP or the dual creatine would be the agent for weight loss. I actually will cover GLP, weight loss management, if that's the agent that should be actually used for those patients who wants to lose weight. And Dr. Tahani will it has been used and probably overused in the community for weight loss. We have so much shortage in medications because of the use and overuse. In cases, some type 2 medication, type 2 patients don't have the medication for their treatments. And I will share the evidence behind all what's happening about GLP and weight loss in this era. We have nothing to disclose. So I have quite plenty of studies. I'm going to share a few that are really important. The first one is a systemic review and network meta-analysis of all medications for weight loss. It is compared to each other and in some instance with lifestyle modification. This is a trial that has included about 143 clinical trials. It liraglutide, semaglutide, and exenatide were in this study. So in the results, we have seen that with about 6% of weight loss in the analysis of 24 trials, and that was for about 1,100 patients in these trials. Now, the second result was weight loss of more than 5 odds ratio that was significantly statistical in 15 trials. Now, to discontinuation of the agents that were used. Now, with the second has really good weight loss with exercise and just exercise alone or liraglutide. Published in New England Journal of Medicine in 2021, diabetes, weight loss was the main outcomes, and there was 4 arms. The first one, liraglutide alone, liraglutide with exercise, and the third one, exercise alone, and the last one is just placebo. So the outcomes here was weight loss for about 3.4 with the liraglutide with exercise, and the p-value was significant. Now, moving to the other arm that was liraglutide alone, we have seen less than 1 kilogram of weight loss. So here we can say that liraglutide with exercise is necessary, as you can see it in the red line and the red block. Another study actually we have here for liraglutide that was done again and published in the New England Journal of Medicine that showed that liraglutide 3 milligrams in addition to diet and exercise may reduce weight in adults with obesity and without diabetes. So in this trial, liraglutide has shown community. This so 100 patients. The sample size was female with obesity and no diabetes. Semaglutide versus placebo over 68 weeks. BMI more than 30 kilogram per meter square, and the goal was that semaglutide achievement that is up to 15% 14.9%. So this is really I'm going to conclude with the last trial here for semaglutide, and this is for the once-weekly semaglutide versus liraglutide in adults who were overweight without diabetes and receiving consultation for diet and physical activity. This trial was last trial published in JAMA 2022, randomized, non-blinded. Patients were randomized to 4 arms, either liraglutide or semaglutide, placebo daily and placebo weekly. But those patients who were on the active medication were not blinded for the medication. Those patients had the BMI of 30 or 27 BMI plus a chronic condition. And the results of this trial, you can see here that there was a significant difference after week 28 to the end of the trial, and the semaglutide had weight loss more than liraglutide in this trial. And the weight loss was 15.8 compared to 6.4 weight loss in the semaglutide versus liraglutide. So here the p-value actually was significant, but as you can see it as well, it's in the graph here. And with that, I end the evidence behind both agents, the semaglutide and the liraglutide, and I will leave the podium for Dr. Tahani to share her evidence of the new agents and the weight management. Thank you.
السلام عليكم، سعد مساءكم جميعا. Thank you, Dr. Umayma. We've known GLP-1 receptor agonists for a while now, since 2005, and it's made a lot of impact on our approach on how to manage type 2 diabetes and how to manage obesity. So the novel glucose-dependent insulinotropic polypeptide, in addition to glucagon-like peptide receptor agonist, it's been evolved lately, and the only medications in this class is tirzepatide, and it's the only one that work by activating glucose-dependent insulinotropic polypeptide in addition to its effect on GLP-1 receptors. It's a once-weekly medications that administered subcutaneously, and it's received the US FDA approval to be used in type 2 diabetes in May 2022. And just a couple months ago, it's received the approval to be used in weight management in October 2022. However, in Saudi Arabia, the approval application is still under the process in Saudi FDA. And I'll discuss in this topic 2 trials. The first one is SURMOUNT, phase 3 obesity trial. It evaluates the efficacy and safety of tirzepatide in comparison to placebo for the weight management. The data of these trials has been published in New England Journal of Medicine in July 2022. It's a phase 3, multi-center, double-blind, randomized placebo-controlled trials, and it's conducted in 119 sites in 9 countries. A total of 2,539 individuals without diabetes, but they have to have obesity with a body mass index of 30 or more, or overweight with a body mass index of 27 or more, at least 1 weight-related complication. Patients were, all participants went through screening, then they randomized to receive either tirzepatide either tirzepatide 5 milligram or 10 milligram or 15 milligram or the placebo. The dose of tirzepatide initiated at 2.5, then the dose is increased by 2.5 every 4 weeks until they reach the randomly assigned dose. The follow-up or the total duration of treatment was 72 weeks. However, if the patient have pre-diabetes at baseline, they will follow up with them for additional 2 years. It looks at the efficacy and safety of tirzepatide in comparison with placebo, and their primary endpoints include percentage change in body weight from baseline to week 72, and also they look at the proportion of patients who meet their weight reduction target of 5% as a primary endpoint. For the secondary endpoint, they look for the proportion of patients who reach weight reductions target of 10% and 15% and 25% and 20%. And also they look at the changes in weight from baseline to week 20 and also any changes in waist circumferences. So there's two graphs in front of you. The one on the left look at the treatment effect of tirzepatide in respect to placebo for all participants who undergone randomizations, and regardless if they have discontinuations of treatment. For the one on the right, it includes the treatment effect of all participants who undergone randomizations. However, they have to receive, or if the treatment was administered as intended. So we see that there is a 15% weight reduction with tirzepatide 5 milligram, and 19.5 weight reductions in tirzepatide 10 milligram, and 20.9% weight reduction in tirzepatide 15 milligram compared to placebo 3.1% weight reduction. The proportion of patients who meet the target of at least 5% weight reductions was 90 with tirzepatide 50 milligram, which means for each 10% receive tirzepatide 50 milligram, at least 9 of them will get the benefit, or 9 of them will get at least meet their target of 5% reduction. Compared to a placebo. In terms of waist circumferences, the benefit of tirzepatide in waist circumferences already seen compared to placebo. However, the 10 milligram and 15 milligram was similar, and not a lot of difference between the two doses, 10 milligram and 15 milligram. Also, tirzepatide shows benefits in all secondary endpoints, including physical function scores, lipid levels, and diastolic blood pressures, and cholesterol. The most frequently adverse event that lead to discontinuations was GI side effect, including nausea, diarrhea, and vomiting. However, interesting thing that we see COVID-19 within the adverse effect, but keep in mind that this studies was conducted between the period from December 2019 to April 2022, where COVID-19 was an epidemic at that time.